you've got a 48-year-old male, an engineer, whose BMI is practically 50, and he comes to you in an emergency situation with a large ventral hernia. He's saying that he's got pain and he's presented to you with some amount of bilious vomiting. You manage him conservatively and the obstruction settles down. On his history, you find that he's a known hypertensive, and he tells you that, doctor, please make sure that my hernia is taken care of and also my weight is taken care of in the same setting. What you do at that point is go in laparoscopically, you perform a sleeve, you do an open hernia repair. 1 year later, the patient is really happy because he's managed to lose down till 92 kilos. His BMI is down to 31.1. And at this point, he becomes a little complacent maybe. And he directly comes to you after 3.5 years. He's already put on another 30 kilos of weight. His lipid profile is deranged. His hernia has recurred. And he's also complaining of some amount of acid reflux. What would you do, Dr. Palep?
So again, now we have this particular situation. He's come after 3.5 years.
Yeah.
And he is put on some weight. His lowest was 92, right?
Yes.
He reached 92 and now he's back 30 kilos. He's still off pills, antihypertensives. He's got a recurrence of the hernia. He's got acid reflux. Like to go in and investigate, do an endoscopy, figure out whether he has a hiatal hernia again. Now he had undergone a sleeve, right?
Yes.
Yeah, right. So ask him for all the other factors of weight regain, whether his lifestyle, because he stopped, following a healthy lifestyle, whether counseling him would bring him back to a healthy lifestyle. And obviously, since the recurrent hernia has to be repaired and you've performed an endoscopy and you find that there is probably a reflux also associated. I don't know, he has reflux, right? Yeah. So then we'll have to obviously perform a hernia repair, which means that he's going to go on the OR table. We might as well convert the sleeve into an RYGB, which will assist him probably to lose some more amount of weight, cure the reflux, and take care of the hernia. Obviously, re-emphasizing the importance of going back to a healthy lifestyle simultaneously.
Okay. Dr. Bharucha, you mentioned about revision bariatric surgery and its relatively poorer outcomes as compared to a primary surgery. So would you agree with Dr. Palep's management in this scenario?
The thing that I'm looking at over here is that you said that he's developed dyslipidemia. Now I don't know how much dyslipidemia he had before the surgery and how much he has now.
Mm-hmm.
But now he's going into metabolic problems, and we've just got a sleeve gastrectomy and a hernioplasty done before. Now he's come with a recurrent hernia. He's come with the reflux, which means that if the reflux was not there before, that means this is a de novo reflux that has developed after the sleeve gastrectomy. And if, as Dr. Palep mentioned, that on an endoscopy, I find that along with the complaint of GERD, he also has a reflux esophagitis or a significant hiatus hernia or Barrett's changes. Then the sleeve has to be converted to an RYGB,
right?
And which will also take care of the dyslipidemia. You might have to alter the limb lengths according to what other patient factors you find. And he's also off the antihypertensive pills. Now about the hernia recurrence, I mean, I would be a little hesitant to do a hernia surgery at the same time that I do the sleeve to RYGB, simply because this guy is not compliant at all. I would now tell him that unless you lose a certain amount of weight, that you will have to wait for 6 months to a year before I do a hernia repair, unless of course you get a complication of the hernia.
Okay. Dr. Praveen, you've got a large series of hernia repair along with bariatric surgery. So what is your opinion on this case?
So I think this is a trickier discussion, although on certain one or two points of Dr. Bharucha, I may not agree, but then I'll share my thoughts on. See, there are three aspects to be looked into. One is the GERD aspect of it, second, the hernia, and third is the weight regain. Now we need to understand, see, the hernia part of it and the GERD aspect of it, we doctors need to give him the recommendations. But the weight regain aspect of it, the patient needs to tell us what he would want. So is he really concerned about the weight loss? I mean, weight regain? Is he wanting to do something? Or is he in a mood that he will take care of himself, or does he want us to do a redo bariatric? So this is a discussion that we need to have separately. If the patient says, I can manage on my own, though no worry, this weight train, no, I will try my lifestyle measures, I don't want to redo bariatric, blah, blah, then this redo bariatrics from that aspect is out. But if he is wanting redo bariatrics, then you need to counsel him, a multidisciplinary therapy, everything comes. So leaving that aside, let's move to the second aspect of the GERD. Now, if he is, I think you just had mentioned acid reflux. Now we need to know the extent of acid reflux. Is it debilitating or is it causing a lot of clinical issues as such? Plus, endoscopically, you need to look into how bad is esophagitis. Is there any signs of Barrett's, etc.? Because if the reflux is bad, and if the reflux is really debilitating to him, or is it causing Barrett's, then as surgeons, we need to intervene because there's an indication for an anti-reflux procedure. What do we do as an anti-reflux is the second aspect. We'll talk about it. Third thing with regard to the hernia. Now he has a recurrence, and any hernia needs to be operative irrespective of the symptom. This is an age-old thing. We cannot wait for a complication to happen, especially when there's a weight loss that's going to happen. Patients need to exercise. They need to strain themselves. The hernia is only going to get complicated. So the hernia needs an immediate surgery. So there is no question of having a surgery now. The question is what all along with the hernia is the question that we need to take. Now, let's say in my case, in this patient, I will definitely do a laparoscopic IPOM for sure. But if the patient is not interested at a redo for weight loss as such, then although this is too early to talk about it, although the gold standard would still be Roux-en-Y gastric bypass, on a personal note, I have a very good experience. I will go ahead and do a ligamentum teres cardiopexy. That will act as an anti-reflux procedure because he's not now interested in weight loss, or GERD is the only trouble. I will do an IPOM with a sling. But if instead of that, I will try to counsel him, telling a bypass will actually give him the weight loss outcomes and also the reflux. And if he's willing for that, then end up doing an IPOM along with a Roux-en-Y gastric bypass. If nothing, I mean, if the reflux is not severe, it's not an issue, just an IPOM.
Right. So you can see that, just in one particular scenario, once again, we've just got so many different varying opinions, everybody who would tackle everything very differently. And one thing which I do believe everybody is stressing on is one, the kind of patient symptoms, what the patient is mainly coming to you with complaints of, whether it's the hernia, whether it's a GERD, whether it's the weight regain, and ultimately what does the patient want and how much is the patient eventually going to comply with whatever therapy you offer for.